Thank you, Andrew. And as a Tar Heel, I'm happy to say that Duke lost to Florida State by a lot less than University of North Carolina. So this afternoon, the rest of this afternoon, we're going to be talking about what does the clinical environment, what is the marketplace for which all these wonderful technologies that we heard about this morning trying to enter into. So if we think about personalized medicine, what is it? It is a capability, it is technologies, but most important, it is use to improve people's health and lives. So I would say that one of the main areas of focus that we need to have as a movement of introduction of personalized medicine to improve the lives of people is to understand what is that market in which we are trying to put our technologies. So if I could have the first slide, please. So, medicine is very, very heavily driven by science and technology. Up until the early part of the 21st century, we were driven by basically the science and technologies that developed in the early 19th century or the early 20th century, very heavily driven by the types of sciences that allowed us to understand the very basic aspects of disease. However, roughly in the year 2000, there was a confluence of a lot of emerging science and technologies, genomics, proteomics, metabolomics, systems biology, which is a dynamic concept of the evolution of disease from health and sometimes health from disease, informatics, microprocessing, nanotechnologies, et cetera, that when one thought about what is the use of all this information, for the first time we could render medicine from its focus on specific points of disease to understand the dynamics of health and evolution of disease. And that's when I got very interested in this as, at that time, head of the Duke University Health System, and understanding that disease is not a point in time. Disease is part of a dynamic process. So it's not an endpoint, it is a stage in a dynamic process. And what was ironic and very disturbing to virtually any citizen of the United States, particularly those in healthcare, in that what we have now is a $2.5 trillion industry was being practiced in a way that made no sense if one understands the dynamic process of disease. And that is, every disease, if we understand that it's dynamic, it's based on what we inherit genetically, gives us boundary resistance or susceptibility to any particular disease. Diseases develop over time. They tend to be subclinical for a long time. And when they become clinically apparent, there generally is a lot of underlying pathology. What was ironic is that we were treating disease at a fairly late stage in which the costs were high and the reversibility was low, and it made no sense whatsoever. So the field of personalized medicine in its modern form started to emerge very heavily in roughly 2000, got a lot of excitement from the sequencing of the human genome and the anticipation that emerging sciences for the first time were going to allow us to intervene earlier, to predict, to prevent, to personalize, and importantly, to get people involved in their care. In order to do this, we needed to be able to assess an individual's baseline risk, and for some diseases, genetic inheritance is very predictive. In others, it's much more diffuse and hard to understand, much more complex. But nonetheless, there are ways to track whether or not disease is developing or not, to be able to anticipate major disease events before they occur and to intervene. And then once a decision is made that there needs to be a therapeutic approach, to have the capability of differentiating one individual from another individual to give the appropriate therapy, but even at that time, to predict adverse outcomes and to monitor progress. So that was the very, very big hope, and a lot of anticipation, a lot written about it. And if you say, well, what has happened from roughly 2000 now to 2012? Well, a lot has happened. We heard a lot about this morning, and we'll be hearing more about this. The ability to quantify health risks with health risk assessment tools, some genomic, some proteomic, various other epidemiological tools to be able to quantify an individual's risk. To be able to monitor progression. Is an individual, what are those biomarkers that indicate that something is developing or not developing? The ability to specifically classify a disease. As we heard this morning with Brian Drucker, the idea or the direct demonstration that there are different specific causes for many different forms of cancer, and they need to be treated differently. So we have to understand the precise molecular basis of disease. We're learning more and more about that. Clinical model risk tools, adverse outcome predictors, and then selecting therapies. Again, we heard a lot more. You heard from Brian and others having targeted therapies and companion diagnostics. So there is a tremendous abundance and excitement of new capabilities to deal with the human clinical issue. Now, is this the way we want it to be? Have things worked out the way we have expected it to be? I could say for one, who started thinking about this very, very seriously in the late 1990s and looking at where we are today, while there is a plethora and in many ways even more exciting opportunities than I ever imagined, the actual impact of personalized medicine on clinical practice as I see it is really de minimis. That may be an overstatement. When you start curing people's disease, cancer, that's not de minimis. But if we look at the entire panoply of how physicians practice medicine, in most instances, it is not heavily impacted yet by personalized medicine. If you look at how most people lead their lives, there are a lot of early adopters, but most people are not yet impacted by these great technologies of personalized medicine. So how do we think about that? Well, the way I think about it is that research and development technology creates opportunities. They create a push, a new capability. But in order to be useful, they have to reach the market. They have to be used. The market, on the other hand, has a pull. It has needs. One needs to understand what is the market asking for. Sometimes the market isn't asking yet, and you could anticipate what the market might be asking. But even with that, it can be done by understanding what is it that people really want that they don't yet have. So normally, with most businesses, there is a precise understanding before somebody starts a business to saying, what is the market asking for? What is the problem that I'm trying to cure? How is this going to fit in? I would say, from somebody who's been involved in medicine all my professional life, we very rarely think about the market. We think about what we could offer and assume that somewhere out there there is a need for what we do. And that's the way we run most of medicine. You know, we assume that somewhere out there there is a patient that will benefit from what it is that we do. Most businesses don't run that way. They really carefully analyze what is it that the individual needs, and let's design our products to meet that need. So this arrow of personalized medicine tools reaching to the clinical market, and then the clinical market giving the information of what are the tools that are needed or capabilities, is not quite working as well as it should be in our field. And I would say, you know, what are the main obstacles? Well, one obstacle, and this is a great conference, it's going to deal with all three of these. One is regulatory issues, unanticipated difficulties in understanding what will be needed by our technologies to meet the needs of the regulatory agencies. I'm not going to talk about that. The other, which is maybe even bigger, is the issue of reimbursement. How in the world do we get paid for what we developed and get paid fast enough to meet the needs of the early investors? That is a critical, difficult need. I'm not going to talk about that. Hopefully, some of our speakers after me will mention it. What I do want to say a word about is clinical adoption. Another frustrating thing is that there is a test developed. The test developers and the company and the investors all think that this is the most wonderful thing, that it's going to solve all these problems, and physicians just don't put it into their practice. You have to almost beat them over the head to even get them to listen as to how they should incorporate your new technology into their practice. So clinical adoption, understanding that the way physicians practice is very arcane, believe me, and it's hard to bring something new into a clinical workflow. So let me end by giving you kind of an example of how things are done and how I think we need to approach them, and how I think all new emerging companies in the field of personalized medicine need to start thinking about clinical practice if they are selling primarily through the physician. Just making this up, consider a 28-year-old man with a mass in his neck, newly discovered. Any physician will tell you that this may be congenital, this may be infectious, this may be neoplastic, cancer. If it's cancer, it could be a lymphoma, or it could be a metastatic disease. It could be many, many different things. So you need to go through a differential diagnosis. That's what doctors do. That's how they're trained. That's what they enjoy doing. Now, what a differential diagnosis is essentially a decision tree, where this young man comes in with a mass in his neck. The first thing the physician needs to do, and this may be a series of physicians, is this cancer? It may be something else. If it is cancer, what type of cancer is it? So this is a series of decisions that have nodes in which different types of information can weigh in to making that decision, which may be more or less quantifiable. Based on that decision, another series of decisions need to be made, tested, and then therapy selected. When therapy is selected, then one needs to track the patient to see if they're getting better, worse, or cured. So if you really think of what doctors do, they do this. They have this inherent decision tree: diagnosis, treatment selection, follow-up. Now, do doctors realize this when they're in practice, that they are dealing with this beautiful, complex decision tree? No. If you look at 10 physicians, even in the same clinic, I will say with some embarrassment, if you look at the breast cancer clinic at Duke, where you have people who have trained all their lives just to treat breast cancer, you would think they all do it the same way. They don't. So there is no formal adherence to this decision tree. What I think that we need to start understanding when we are selling into this type of clinical environment is that this is the way it is right now. It is very hard for a startup to say that they're going to be changing the clinical environment, but they need to understand where in that decision process does their